All right, today we're doing a clinical masterclass on pyelonephritis. This is an infection that really demands we're on our A game with diagnosis and management. We're going to push past the basics and really build a high-level understanding of the disease, the best ways to treat it, and the ever-growing problem of antibiotic resistance.
So here's our roadmap. First, we'll get a solid definition of the disease. Then, we'll walk through the entire diagnostic process. We'll get into the nitty-gritty of the pathogens and their resistance patterns, cover treatment for both adults and kids, and wrap it all up with the potential complications and the most important takeaways.
Okay, let's kick things off. What exactly is pyelonephritis, and who should we be most worried about getting it?
At its heart, pyelonephritis is a UTI that has decided to move on up. It's not just a bladder infection anymore. It gets its start in the renal pelvis, the kidney's main collecting funnel. But the real trouble starts when that inflammation invades the kidney tissue itself, the parenchyma. That's the key step. That's what triggers the systemic symptoms and separates it from a simple, uncomplicated cystitis.
Now, in adults, the signs are usually pretty textbook, right? You get that classic triad: fever, chills, and that telltale flank pain, often with nausea and vomiting along for the ride. But with kids, it's a whole different ballgame. The signs can be incredibly vague. They might just seem generally unwell. They're not feeding right, or they're just really irritable. This is so critical because it means you have to maintain a high index of suspicion to catch it early and avoid delaying treatment.
So what sets the stage for this infection? Well, things like anatomical abnormalities in the urinary tract are a big one. Or if someone's recently had surgery, a catheter, or even a prostate biopsy, any kind of instrumentation really. But here's the kicker you can't forget. A history of recurrent UTIs is more than just a risk factor for another infection. It's a massive predictor that the bug you're dealing with this time could be multi-drug resistant. And that, right there, has to shape how you think about your initial antibiotic choice.
Okay, so we know what it looks like clinically. Now let's trace the diagnostic pathway. Because getting the pathogen ID right is the absolute cornerstone of effective therapy.
The workflow here is pretty systematic. It all starts with a good, clean catch midstream urine sample. From there, a quick dipstick for nitrites and leukocyte esterase can give you a strong hint that you're on the right track. But that's just a clue. The definitive diagnosis, the smoking gun, comes from the urine culture, which lets us isolate the actual organism. And finally, the most crucial step, susceptibility testing. We have to know which antibiotics will actually work.
The microbiology lab doesn't just use a one-size-fits-all approach. Their choice of culture media is actually tailored based on what we're suspecting clinically. For example, if we think a gram-positive bacteria is the culprit, they'll use a CNA plate to help it grow. In neonology, where you always have to worry about fungal infections, a SAB plate gets used. This targeted selection is what helps us get an accurate ID so much faster.
Which brings us to a moment of levity. Why did the microbiologist break up with the bacterium? Because it had commitment issues, especially when it came to gram staining.
All right, back to business. Let's dig into the core of the problem, the pathogens themselves, and more importantly, the defensive weapons they carry.
When you look at the epidemiological data, it's not even a contest. Sure, you'll see other bacteria pop up like Enterococcus, Klebsiella, and Pseudomonas, but the undisputed champion of pyelonephritis is Escherichia coli. It is responsible for the vast majority of cases. So when you hear pyelonephritis, your brain should immediately think E. coli.
This resistance data is absolutely critical for making smart, empirical choices, especially for uncomplicated UTIs. You can see that for drugs like nitrofurantoin and fosfomycin, E. coli resistance is still really low, around 2%. But then you look at trimethoprim, resistance rates are often pushing past 20%. That makes it a really unreliable choice in many places. It's the perfect illustration of why you must know your local antibiogram.
And here's a number that should really make you sit up and pay attention. 5.7%. That's the prevalence of ESBL producing E. coli. ESBL, or extended spectrum beta-lactamase, is basically a superweapon for bacteria. It's an enzyme that destroys most of our go-to penicillins and cephalosporins. The presence of an ESBL producer completely changes the game. often forcing an escalation to carbapenems and making susceptibility testing absolutely non-negotiable.
So this massive challenge of resistance leads us right into our next section, adult treatment protocols. How do we take all this data and turn it into an effective therapy, starting with a good, educated guess and then refining it with precision?
For an adult sick enough to be hospitalized, the standard protocol is to start with a broad intravenous regimen. A common one is cefuroxime plus a single high dose of gentamicin, which gives you great synergistic coverage against gram-negatives. And you can see there are specific protocols if you suspect enterococcus or even a candida infection. But the whole strategy is built around de-escalation. As soon as you get those culture results back, you want to switch to a narrower, targeted oral antibiotic.
Now let's switch gears to the pediatric population. Treating pyelonephritis in children requires a really different, age-sensitive approach. It's not just a matter of smaller doses.
For kids over 3 months old, the management plan hinges on one key clinical sign: fever. If the child is afebrile, you might manage with a short, 3-day course of an oral antibiotic. But the second fever enters the picture, that tells you this is an upper tract infection. It signals that you need a longer, 10-day course of a broader agent like amoxicillin clavulanic acid to really knock it out and prevent any potential kidney scarring.
And that brings us to our final and maybe most important section. Why is getting this right so critical? Let's talk about what can go wrong and really understand the stakes.
The stakes are incredibly high. An unchecked infection can lead to permanent scarring of the kidney tissue, which means a long-term loss of renal function. It can escalate into full-blown sepsis and septic shock. And even after you've treated it, it can lead to long-term problems like recurrent infections or chronic prostatitis in men. For vulnerable patients, like transplant recipients, it's an even bigger deal. These risks are exactly why prompt, effective treatment is completely non-negotiable.
Okay, let's put this knowledge to the test. Here's a quick case. You have a 5-month-old infant who presents with a fever. What's the recommended oral antibiotic regimen and for how long?
The correct answer is amoxicillin clavulanic acid for 10 days. The two key determinants here are the age, over 3 months, and the presence of that fever. The fever is the big clue that this is a complicated UTI that needs a longer, more aggressive course of treatment.
All right, one more for you. Which of these is the most common bacterial pathogen that we isolate from patients with pyelonephritis?
And the answer is C, E. coli. As we've established, this bacterium is the dominant player by a mile. And that fundamental fact is what guides our initial treatment choices almost every single time.
This brings us to the central challenge we're all facing. We understand the pathogen, we understand the therapies, but what we're in is an evolutionary arms race. With antimicrobial resistance on a relentless climb, the question I want to leave you with is this. How are our strategies, both for diagnosis and for treatment, going to have to evolve to keep up with this very common yet potentially devastating infection?